Hello everybody, welcome to Radiology. Today it's about the most vital organ in the body, the heart. Please don't get heartbroken, although we are going to discuss about the failing heart and its chest X-ray findings. The congestive heart failure is basically the heart's inability to pump blood effectively due to structural or functional impairments. I'm not going to elaborate on the clinical features, pathophysiology, or various types of heart failure, but I will concentrate on the information with related to the radiological or chest X-ray findings. The left ventricular failure is the commonest. Due to reduced cardiac output, there will be increased back pressure from left ventricle to the left atrium and then to the pulmonary veins, causing increased pulmonary venous pressure, leading to leakage of fluid into interstitial pleural space and then into the alveoli, resulting in PE and PE, pleural effusions and pulmonary edema. Unlike left ventricular failure, in right ventricular failure, there will be increased systemic venous pressure, resulting in edema in dependent tissues and abdominal viscera. Most of the chest X-ray findings are due to increased pulmonary venous pressure in left ventricular failure. There are stages of congestive heart failure. Stage 1 to 3. Stage 1 is redistribution phase, where there is redistribution of pulmonary vessels, cephalization, and cardiomegaly as well as broad vascular pedicle can be seen in the same stage. Then, due to interstitial edema, there will be curly lines, peribronchial cuffing and perihilar haziness, and thickened interlobar fissures. Stage 3 alveolar edema, there will be consolidations with air bronchograms, and there may be cotton wool appearance as well as pleural effusions. In practice, we use pulmonary capillary wedge pressure because it is related to the increased pulmonary venous pressure. So, in practice, we measure pulmonary capillary wedge pressure to assess the increased pulmonary venous pressure. And with that, we can grade the heart failure into stages, which gives us a logical sequence of features in congestive cardiac failure. Phase 1 from 13 mm mercury to 18 mm mercury. Stage 2 from 18 to 25. Stage 3 about 25. This is increasing pulmonary capillary wedge pressure. So, which will lead to various features: redistribution, cardiomegaly, vascular pedicle widening, widening of dilatation of azygous vein, curly lines, perihilar haze and peribronchial cuffing, thickened interlobar fissures, pulmonary edema, pleural effusion, likewise. But these features may not be present in all the patients, and this will not occur in this sequence. So, some features may be absent, and sometimes most of these features may be absent in a chest X-ray. But because of that, we cannot exclude heart failure on chest X-ray findings. Now let's elaborate on various stages of congestive cardiac failure. Stage 1 is redistribution of pulmonary blood flow. Initially, there will be upper lobe pulmonary venous diversion. In normal erect chest X-ray, the upper lobe vessels are smaller in diameter and fewer in number. In erect chest X-ray, because of the gravity, the lower zone vessels are more prominent. But with congestive cardiac failure, first there will be equalization of blood flow. That means upper lobe and lower lobe vessels will be more or less equal in size. Subsequently, with redistribution of flow from lower lobe to upper lobes, the upper lobe vessels will dilate more than 3 mm in diameter in erect chest X-ray in full inspiration, and that is called cephalization. The normal diameter is only about 1 to 2 millimeter. This occurs because in a normal erect chest X-ray, because of the gravity, more blood pools in the lower lobes and upper lobe vessels are not dilated and some are not opened up. But in congestive cardiac failure, with increased blood volume, the upper lobe vessels open up more and more and the diameter increases, and this is called cephalization. The arteries also dilate. The artery to bronchus ratio. In a normal chest X-ray, the upper lobe arteries are smaller than accompanying bronchus in erect position. Ratio about 0.85. At hilum, they are equal, and lower lobe arteries are larger than the accompanying bronchus. Ratio about 1.35 due to gravitational effect. But in congestive cardiac failure, the upper lobe and middle lobe arteries dilate more than the accompanying bronchus. This is best visible in the perihilar region. In this X-ray, the perihilar region, the artery is larger than the accompanying bronchus in congestive cardiac failure. Okay. Then we will be able to appreciate cardiomegaly in this first stage. You already know how to measure the cardiothoracic ratio from widest horizontal diameter of the heart and widest thoracic diameter at the inner edge of the ribs. So heart diameter is A plus B and thoracic diameter C. If it is less than 50%, it is considered normal in a non-rotated posterior anterior erect chest X-ray with good inspiration. If it is more than 50%, it is considered as cardiomegaly. But this is not accurate in supino AP films because of the magnification of heart shadow. So if you only have supino AP images, it is better to compare with the old films. Therefore, you may be able to appreciate if there is significant increase in size compared to the old films. Then the vascular pedicle. The vascular pedicle is an indicator of the intravascular volume. Vascular pedicle width less than 6 cm is seen in 90% of normal chest X-rays, PA chest X-rays, if non-rotated. If it is more than 8.5 cm, it is pathologic in 80%. 5 mm increase in vascular pedicle width equals to 1 liter increase in intravascular fluid. So how to measure this? It is measured from the right side margin of the SVC to the left side margin of the left subclavian artery. The SVC is measured as it crosses the right main bronchus. So that is the right side margin. And the left side margin is the origin of the left subclavian artery. This is the left margin of the origin of the left subclavian artery. This is the right side margin of the SVC where it crosses the right main bronchus, and this is the width of the vascular pedicle. Increased vascular pedicle width associated with increased width of the azygous vein. But because of the wide range of values of vascular pedicle width, it is best to compare serial chest X-rays to assess whether there is progressive increase in vascular pedicle width. This measurement is important in differential diagnosis also because normal vascular pedicle width most common in ARDS and acute cardiac failure. Widened vascular pedicle width most common in overhydration, renal failure or chronic cardiac failure, and it can be narrowed in ARDS. Then the increased vascular pedicle width is also associated with dilatation of the azygous vein. The dilatation of azygous vein is a sign of increased right atrial pressure. So this is the right paratracheal stripe and this is the azygous vein. The diameter changes with the position. Standing position, more than 7 millimeter most likely abnormal, and more than 10 millimeter is definitely abnormal. But in supine patient, more than 15 millimeter is abnormal. There is 3 millimeter increase in comparison to the previous films, which is suggestive of fluid overload. Another important thing is the inspiration film and expiration film difference is only 1 millimeter. So this is you can used in expiratory film as well. So valuable tool if you don't have good inspiratory film. The azygous vein width is valuable in assessing a expiratory film in congestive cardiac failure. In summary, the stage 1 or the redistribution stage, the pulmonary capillary wedge pressure 13 to 18, and we have discussed about redistribution of pulmonary vessels or cephalization, increased arteritic bronchus ratio, cardiomegaly, broad vascular pedicle, and dilatation of the azygous vein. Okay, now let's move on to the second stage or the interstitial edema stage. With further increase in pressure within the capillaries, the fluid leaks into the interlobular and peribronchial interstitium. When the fluid enters the interlobular interstitium, there will be thickening of the interlobular septa called septal or curly lines. Most important are the curly B lines. They are peripheral horizontal short 1 to 2 centimeter lines extending up to the pleural surface and perpendicular to the pleural surface, and more frequent near the costophrenic angles. Curly C lines are also similar, but they do not extend up to the pleural surface. Curly D lines are also similar, but only seen on the lateral X-ray in retrosternal airspace. The curly A lines are different and less frequent, and they are long 2 to 6 centimeter and radiating from the hilum. They are less than 1 millimeter in thickness. So these are the curly A lines, are the curly C lines, are the curly B lines. Then the peribronchial cuffing and perihilar haze. The fluid leaks into the peribronchovascular interstitium. Fluid leaks into the peribronchovascular interstitium and there will be thickening around the bronchi. This is called peribronchial cuffing. And because of fluid leakage, the normal sharp demarcation of the vessels are not seen in congestive cardiac failure. Because of leakage of fluid, there will be haziness in relation to the vessels. This is called perihilar haze. Then the fluid leaks into the interlobar fissures, the major fissures. This is the oblique fissure which is thickened due to fluid, thickened interlobar fissures. In summary, in the stage 2, the pulmonary capillary wedge fissure 18 to 25, because of fluid leakage into the interstitium, we will be able to see curly lines, peribronchial cuffing, hazy contour of the perihilar vessels, and thickened interlobar fissures. Let's move on to the stage 3 of congestive heart failure or the alveolar edema stage. With continuous fluid leakage into the interstitium, which is not compensated by lymphatic drainage, the fluid will ultimately leak into the alveoli and into the pleural space, causing alveolar edema and pleural effusion. Fluid in the alveoli will be seen as perihilar opacities or consolidations with air bronchograms, and also cotton wool opacities. The distribution of alveolar edema, however, depends on gravity and obstructive lung disease. The distribution will be different in supine or erect chest X-ray or in the right or left decubitus X-rays. And in obstructive lung disease, the fluid tend to leak into the normal or less affected areas of the lungs more than the diseased areas. In this chest X-ray, we can see perihilar opacifications with air bronchograms and the pleural effusion. Apart from that, the cardiomegaly, increased width of the vascular pedicle and dilated azygous vein also can be seen. The classic bat wing opacifications, perihilar consolidations mimicking bat wings. Then the pleural effusion, usually bilateral, more on the right side when it is unilateral. Here the costophenic angles are blunted, especially on the right side, due to pleural effusion. This is more clearly seen on a lateral chest X-ray, because to visualize fluid in the chest X-ray, in the PA at least 175 milliliters and lateral even more than 75 milliliters can be seen. But in supine X-ray, it is difficult to appreciate because at least 500 milliliters of fluid is needed. Pleural effusion is not always visible as meniscus in the costophenic angles. These are images of patient with congestive heart failure. So what do you think? What is this? Elevation of hemidiaphragm? The gastric air bubble is usually immediately below the diaphragm. But here, the apparent diaphragmatic margin is higher with increased width between the gastric air bubble and the diaphragmatic margin. This is because of the fluid. The distance from the lung base to the gastric air bubble is increased because of pleural fluid. This is pleural effusion, not elevation of the hemidiaphragm. In the frontal chest X-ray also, when the diaphragm is elevated, usually the dome is more central. But here, the diaphragmatic dome-like appearance is seen towards the lateral part of the hemithorax, more lateral place. This is due to pleural effusion. The diaphragmatic margin is not seen because of the pleural effusion. This is subpulmonic pleural effusion and it tends to follow the contour of the diaphragm. In summary, stage 3 pulmonary capillary pressure more than 25 millimeter mercury, we will be able to see consolidation, air bronchograms, cotton wool appearance and pleural effusions. Because you all like mnemonics, the favorite ABCDE mnemonic can be used to memorize the chest X-ray appearance in congestive cardiac failure, not in the order of stages. A for alveolar edema, the perihilar opacifications or bat wing sign. B for curly B lines. Then cardiomegaly, C. D for dilated upper lobe vessels. And E for effusion. The chest X-ray features of heart failure are not diagnostic. There are many differential diagnoses, such as ARDS. The bilateral opacifications can mimic heart failure, but in ARDS, they usually starts from the periphery. The heart size is usually normal as well as the vascular pedicle width, which is normal or even reduced, and not usually associated with pleural effusions. Diffuse pneumonias, the opacifications can mimic heart failure but usually not gravity dependent. Pulmonary hemorrhages, the bilateral opacifications can mimic heart failure but again no dependent gradient. That means will not change its appearance with the position of the chest X-ray. For example, erect, supine or decubitus, and usually not associated with pleural effusions. Pulmonary alveolar proteinosis also usually not associated with pleural effusion. I hope now you have some idea how to differentiate heart failure from the mimicking pathologies. I am pretty sure that you are now more confident in assessing a chest X-ray for the features of heart failure. I wish you good luck for your future radiology learning process and thank you for being with me.